Good evening, everybody. Hope you can hear me. So this is another webinar on our series of education on various aspects of weight loss surgery. So today we'll be touching upon what are the different types of operations. So if you were to look at the internet or look into papers and articles, and there's so many different types of weight loss operations, and it can be confusing even for doctors, let alone people who are not in the medical profession. Okay, so let's begin with what are the different types of operations. If you look at weight loss surgery, some of the older operations were the gastric bypass type surgeries, which was started off as open surgeries. People used about 40 years ago. You had a big open cut on your tummy, and then we will go ahead and do different types of procedures to help reduce weight in patients struggling with their weight. So this over the years has evolved to small keyhole type surgery, and it's still a science that's evolving. So there were different attempts at different procedures, and some have come and gone, others have stayed. So the main groups of operation previously, which was quite common, was the gastric band or lap band surgery, which we used to do a fair amount of. And that's slowly come down over the last 3 to 4 years, where we hardly do any gastric bands because we've seen all the problems that arise from gastric bands, as well as the inadequate weight loss and poor quality of eating. So this is something that's we have sort of given up on doing generally. So most of the days, what I do is I'll be pretty much taking bands out half the time. And then if we go on, there's the gastric bypass, then there's a gastric sleeve operation, then some newer ones called Sadio or SIPS, and then a SASI type surgery. So with lap band, what we do, we put a little ring across the top half of your stomach, and it's connected with a tubing, and that ends up with a little connecting port, which is under the skin, somewhere in your abdomen. And this is injected with saline, and that squeezes or compresses that part of the stomach and then reduces your food intake. It is not very effective. It can give up to, when we talk about weight loss in generally with weight loss procedures, we talk about excess body fat loss. So someone's got, say, 50 kilos of excess body fat, then we say whether the surgery can cost 40% of that excess body fat loss, or is it going to cost 50% of excess weight loss, or is it going to be 70, 80, 90% excess weight loss? So if you look at that in that way, then the gastric band usually sits around about 40% of your excess weight loss with it. So it is reversible. You can take it out. However, the damage that it does sometimes is not reversible. So the band and the port and all that, you can take it out at any point. But a lot of times it causes a lot of damage around the stomach, around where the tubing's gone, and in thick scar tissue formation, and your gullet or the esophagus sometimes can be damaged because it's constantly trying to push across this obstruction that's there in the lower end. So this is why it's not very common now, because it requires a lot of management with injections and monitoring, and trying to get the balance right is very difficult, and the quality of eating is usually quite poor with this operation. Okay, and then we talk about gastric bypass operation. So this is another common operation. It's been around for a long time. It has had multiple changes over the years. It was first done about 40 years ago, and over the last 5 to 6 years, 7 years, it's been modified further. So we have things like what's called a Roux-en-Y gastric bypass, and then there's also something called a one anastomosis gastric bypass. So this is actually a very effective operation. It's time proven. There are long-term studies, more than 20 years of data on what it can do. It produces very good weight loss. It can reduce reflux problems that can arise with other operations, and it can have very good control of your diabetes. So losing 70 to 80, 90% of excess body fat, with depending on the amount of the bypass that we do. So effectively what we do, we just staple the stomach, make it into a narrow tube. We're not removing anything. And then we bring a loop of bowel and hook it up to this new tiny stomach. So food now travels down the new small stomach and then goes into the bowel, skipping or bypassing the early part of your bowel. So this is a well-proven operation with good long-term weight loss. There are some side effects. You can, if you took too much sugar, someone said this operation has too much sugar or refined carbohydrates. It can produce symptoms of what's called dumping, where you can get issues with low blood sugars and feeling sweaty and dizzy, and rarely you can get what's called an internal hernia. And what's a gastric sleeve operation? So this is the most common weight loss operation at the moment. So we do this with keyholes. We go in and then we staple and remove a big section of your stomach. So patient stomach capacity about a liter, liter and a half. What's left behind after the surgery is about 150 to 200 mils. So a significant reduction in the size of the stomach. It's not altering the anatomy too much. We're not rejoining bowel or rerouting your food and things like that. So this will reduce the volume as well as reduce your hunger drive, and it gives fairly good weight loss with not too much side effects, other than some about 10 to 20% of people can get heartburn or reflux. So the weight loss you can expect with a gastric sleeve over the long run is about 60% excess body fat loss. And in the short term, you can definitely do better than that. And I have a lot of patients who've had fantastic results long term, because it really requires as well good lifestyle change like any of those weight loss operations. So there's a newer type of operation called Sadio SIPS procedure. This is where a gastric sleeve is done and then the bowel is bypassed at the same time. So this is a fairly what we call a malabsorptive operation. The amount of bowel that's skipped or bypassed is quite long. So you have a very short section of the bowel that's actually absorbing nutrients. Hence, it produces very good weight loss, but it also increases the risk of nutritional problems. So with any weight loss operation, if you look at some surgery that's going to produce a lot of weight loss, it has to give somewhere. So you're going to have some amount of nutritional problems related to these types of surgeries. So it then comes down to weighing what the benefit is of each operation for an individual patient. So some patients, the offset of their nutrition is still okay, provided they are coming for follow-ups and complying with the medication and vitamin requirements. Then there's a new one called a SASI procedure. This is what's called a sleeve gastrectomy and ileal bypass, where a sleeve gastrectomy is done and the bowel is joined straight onto the sleeve. In the previous SADI procedure, it's actually joined to the duodenum, or the first part of your small bowel. Here, the procedure, we join the stomach to the small bowel directly to the sleeve. So this will give you a fairly good weight loss, and it has still connection to the other side of your bowel. And so not complete bypass of that whole section, so you still get some nutrition going down the other way. It's meant to be less problematic in terms of nutrition. However, you can still get bile reflux, and you can get ulcers at the joint if you take medication like Voltaren, Nurofen, anti-inflammatory drugs, or someone who smokes. And it's also a relatively new operation, not many done around the world, wouldn't even be less than 0.5% of operations of these types of surgeries, either Sadio SIPS procedures. So these are all fairly new, last 4 to 5 years, with very limited long-term outcome data. So may look promising, but we can't be sure what the long-term issues are going to be. Okay. So how do we know what's the best surgery for me? So patients always ask me. Some people come in with a preconceived idea that this is the best operation for them. Others come in with not really knowing what's good for them. So this is something that we work out at the first consult. We go through patient's history, we have a good chat, see what their eating habits are, what are the medical problems they may have, what their starting weight is, and what their end aim is to where they want to get down to in terms of their weight. So based on that, then we can decide what would be the best option for that individual person, because there's not really one operation that's going to be fixing everybody's problem. And hence it's a very tailored service that we offer, and we go through things and then we come up with the best plan of action in conjunction with all the other health professionals that work with us, dietitians, psychologists, exercise physiologists, and all these health professionals, allied health, and together we come up with a good plan as to what can help patients get good long-term weight loss. Okay, we are not trying to produce something that's going to give you good weight loss for a year or two and then put weight back on. So we want patients to have a successful outcome in the long term with these types of surgery. So what are the differences in recovery? Pretty much all the, with my patients, generally all my, whether it's a sleeve, a bypass, or even if I did a revision operation from a previous gastric sleeve to a bypass or a band to a bypass for whatever reason, then most of the times patients are spending 1 to 2 nights in the hospital. You'll be able to start driving in about a week, and most people are back to work in 10 to 14 days. So it's not something that's going to put people back in too long, provided you don't have any issues or complications, which is less than 1%. So when you look at weight loss surgery, the major complication risks, things like leakages from those cut edges, bleeding, any of those major issues should be less than 1%. In my hands, it's much, much less than that. And the average industry standard should be around 1% or less. Okay. So there are cost differences between different operations, mainly depending on the complexity and time taken to do the operation. So we look at, say, for example, a gastric band. If you've got private health insurance, you're looking about $3,000+. You'll get some money back out on a rebate with that. If you look at a gastric bypass, you'd be paying around $5,900, and then if you go private health, you'll get about $1,000 back, so $4,000+ out-of-pocket costs. With a gastric sleeve, about $3,000+ out-of-pocket costs. When we are uninsured, then the cost goes up significantly, because then the hospital fees has to be paid by the patient. The anesthetic fees and a few other things are all need to be paid by yourself. Whereas when you've got private health insurance, then they cover most of the costs of surgery. So that then becomes less burdensome. And that sort of concludes the session. And if anyone would like to ask some questions, just use the chat feature there. You can type in any questions you have, and we can go through that quickly and clarify any doubts. Okay, so someone's asked, what happens if we have reflux, and does it get worse with gastric sleeve operation? Yep. So depending on your reflux symptoms, so there's various grades of gastroesophageal reflux. So some people might get a little bit of reflux just because they ate something not right for that day, or ate too much, or had too much alcohol. So then these patients may not necessarily have worsening symptoms. So most of the times I would do an endoscopy. So we'll put a camera down, and we will have a look on the inside to see if there's any complications from reflux. So you can have severe esophagitis, or another condition called Barrett's esophagus, where the lining of your gullet or your esophagus has changed and because of constant acid reflux. In those instances, it'll be better to do an operation which is less refluxogenic or less chance of producing reflux, like a gastric bypass. So when you've got reflux here, it's important to evaluate how it is, and then we would decide what to do. So a lot of times the reflux, if you don't have too much symptoms, patients tell me it's all started coming once they started putting a lot of weight on. And then when we do a sleeve, they find significant improvement with their reflux. Whereas in the same setting, if someone's got very significant reflux prior to surgery and they've got like a hiatus hernia, we fix that up and do a sleeve, they're usually all right. But it depends on the individual and depends on how bad the reflux symptoms are. Okay, the next question is, what is the most common surgery you do, sleeve or gastric bypass? Well, the sleeve gastrectomy is the most common operation I do, and not only me, worldwide, Australia-wide. If you go to UK, you go to the US, the sleeve is the most common operation. The second one will be the bypass. So in my practice, I would be about 2/3 would be sleeve, 1/3 of my operations will be gastric bypass, which is in keeping with what is seen throughout the Australasia and internationally. So the gastric sleeve is a good operation for a big cohort of patients. The bypass, it's reserved generally for people who may require them more. It has a little bit more maintenance issues over the long term. So someone's 76 kilograms and 1.6 meters, will they qualify? Well, we'll need to calculate the body mass index. Just looking at that, it's unlikely. If you go to our website, in Perth Weight Loss and Surgery website, there's a BMI calculator. If you punch your numbers in, it'll give you your body mass index, and that's a relatively accurate measure, and that's what all the hospitals and societies based as a guideline to whom we can offer this operation. So we are governed by that, and it's important to be in at least 35 and above. And sometimes we do consider between 30 to 35 if you are poorly controlled weight-related conditions like severe diabetes, if someone's got very severe obstructive sleep apnea, blood pressure issues related to their weight, yes, then we can consider for a BMI of 30 to 35. But most of the times it needs to be above 35 BMI for surgery. Next question is, I have a hiatus hernia. Can this be repaired at the same time as weight loss surgery? Yes, it is. Yeah. So that's not very uncommon. So a lot of times we do an operation, we'll suddenly discover patients had a hiatus hernia. It's standard practice for myself to fix that at the time of the actual weight loss operation, because if you don't do that at the time, then it can cause problems with regards to reflux and lots of other issues. So it's ideally fixed at the same time, because the operation's all in the same area. It doesn't really take me that much longer, and it's pretty straightforward and something that we do on a weekly basis. So it's not an issue at all to fix a hiatus hernia, and it's should be done at ideally at the time. Yeah. And yeah, I think next question. Some people say they cannot absorb Panadol after having the sleeve done. Is this common? No, not at all. So Panadol is one of the most common pain relief medication we give, and it's not really all absorbed in the stomach. Most of the absorption happens in the bowel, and we are not changing anything like that. So we give Panadol routinely after surgery. And when you go home after an operation like this, Panadol is the basic type of pain relief that we offer. So yeah, no problems at all absorbing Panadol. And generally with the sleeve, it's not going to be any problems to absorb any medication essentially. So it's not really going to be a major trauma. Do I need to stop my aspirin? It all depends. I have done lots of sleeve gastrectomy surgeries on patients who are on aspirin because they need it for their heart condition. And the indication for why you're on aspirin is very important. So if it's just something that the doctors put on just as a prophylactic thing, probably it'd be good to stop. But if someone's had a cardiac stent, they've got a heart issue, and the cardiologist thinks they need to be on this to help reduce a heart attack risk, then we will have to balance the risk of bleeding, and usually aspirin is not a problem. So we've done lots of surgeries with patients on aspirin, and that's never an issue. So there's another question here. Am I best to have a child before or after surgery? Maintaining why is it best to do surgery after having a last child? So it all depends on your age, I guess, and issues with fertility. So weight loss surgery has been proven to reduce complications during pregnancy, and also to increase fertility and increase chances of having children. So if someone's struggling to conceive, their weight is the problem, then an operation to have having a weight loss operation is going to improve things for you and reduce issues. Whereas if you are not very sure about if your fertility is not a problem and your BMI is not super high, then it may be worth getting having a child and then completing your family and going on to have the weight loss operation, and then it's going to be less of a problem. So patients who, I've had a number of patients, we tell advise not to have any children in the first year and a half, and then oops, accident happens, and then they come back in 3 months after an operation. Doc, what do I do? So it's really difficult to manage, and because when you have are losing weight, you're trying to balance your nutrition, your eating is still not optimal, and then if you get pregnant, then trying to balance everything is a real difficult thing. So it's generally advisable that you wait for a year and a half after weight loss operation before going on to have children, and it's usually not a problem. When they compared, a lot of studies have compared patients having children before and after weight loss surgery. There's no issues with the children. Only thing, the babies can sometimes be a bit smaller for the gestational age compared to pre-weight loss surgery, but there's no other major issues related to that. So no problems with having children before or after weight loss surgery. Yeah. Good. I think, is there any other questions? If not, then we can close the session. All right. Let's have a look. So yeah, then anyway, thanks everyone. Thanks for coming online and spending our evening with us. If there's any further questions that you like to chat about, or if you've got any questions, just book in to come and see us. I'm more than happy to go through things with you, and we'll catch up in the next meeting that we have. Bye.